All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance, and public health, sadly, is always trying to keep up. So let's start with today's public health reality check. Your salad, your kids' measles immunity, and a virus carried by South American rodents all have something to say about how we run systems in this country. First up is Cyclospora. The CDC is now tracking at least 1,645 lab confirmed domestically acquired cases since May 1st, plus over 5,100 suspected cases under review across 34 states, with at least 141 hospitalizations. No reported deaths so far. Think of this as filling a mid-sized sports stadium, an entire arena of people whose main shared experience is unfortunately explosive, parasite-driven diarrhea, and a sudden appreciation for toilet proximity. One of the biggest clusters, over 400 people, spans Michigan, Ohio, West Virginia, and Kentucky, with interviews pointing toward lettuce and salad greens. That's not one bad batch. This is the CDC, who is clear that cases don't all trace back to a single source, and investigators are chasing multiple produce items at once. Translation: this isn't a whodunit, it's whodunits, and your friendly state health department is playing foodborne whack-a-mole while outpatient clinics and labs drown in stool samples. Sandy, why this matters. Clinicians have to stop mentally filling Cyclospora under traveler's diarrhea only and start ordering targeted testing instead of genetic OMP, that's ova and parasite panels. Food safety systems clearly struggle when a seasonal parasite scales from a handful of cases to stadium levels, and the supply chain just can't pinpoint where the contamination is coming from. Now, let's do a quick detour to your freezer. The CDC has now flagged an E. coli outbreak tied to frozen blueberries and is telling consumers not to eat the recalled product. Frozen fruit oftentimes feels safe to most families and institutions, hospitals, schools, and long-term care facility because we mentally rank it below raw meat on the things that will betray me list. But an outbreak here reminds us that contamination can hide in low-risk feeling items and forces big institutions to revisit procurement, kitchen practices, and assumptions about what's safe enough to feed patients and kids. And then, of course, there's the measles, the virus equivalent of performance review on your vaccination values. The CDC reports 2,231 measles cases so far across 32 outbreaks, and about 93% of those cases are tied to outbreaks in under-vaccinated communities. Picture a large high school, almost every student infected within clusters that didn't need to exist because we already have a vaccine that's 97% effective with 2 doses. This isn't one unlucky cluster. It's a structural failure in coverage, now burning ER time, PPE, and isolation rooms while schools juggle closures and exclusions. Measles has earned prime real estate in the New England Journal of Medicine, with a recent feature on a regional South Carolina outbreak documenting how the virus walked through schools and communities that had let vaccine coverage slip. When measles gets New England Journal of Medicine column inches instead of just how it's a pediatric sidebar, that's a polite but firm way of saying routine childhood prevention is now a systems problem, not just a pediatric issue. And hospitalists, as well as infectious disease physicians like myself, need to be in the policy conversation about mandates, access, and how we define community responsibility. And quietly, the New England Journal of Medicine is also talking about the Andes virus, a South American hantavirus that causes severe respiratory disease with high mortality and uniquely can spread from person to person. The CDC reminds us that rodents carrying it haven't been found in the US, but it can spread via rodent excreta and close contact with infected people, with symptoms appearing 4 to 42 days after exposure, and no specific antiviral or vaccine available. In other words, you don't need your local rodents to have global risk, just global travel, fragile health systems, and a willingness to ignore the word hantavirus because it sounds too exotic to be relevant. I recorded a video on this New England Journal summary, as well as my additional commentary, I think about 3 or 4 videos ago. And I think I titled it Final Thoughts on the or the HV Hondius, the Andes virus. You can find it on this channel. All right. I never thought I would say this, but let's move over to our senator, the Republican from Louisiana, Senator Bill Cassidy, who is a physician and a current chair of the Senate Help Committee, who spent a confirmation hearing openly furious at a nominee for repeating vaccine misinformation. That's the part I never thought I would hear, is actually Republicans pushing back against vaccine misinformation. This nominee is Sean Kaufman. He's President Trump's pick to lead the ASPR, the Federal Health Security Agency that oversees national stockpile and BARDA. Kaufman has a history of vaccine skeptic messaging, including a now deleted LinkedIn post questioning newborn hepatitis B vaccine and implying that there are links to autism, links that do not exist in science. At the hearing, Cassidy slammed this to Kaufman, saying, "Why do you repeat these damn lies?" and calling out the damage of casting doubt on mRNA technology, which he described as a cornerstone of rapid response to emerging biological threats. But here's the twist. This new, very direct version of Cassidy is showing up after he lost his primary to a Trump-endorsed candidate. In other words, now that the political cost has been already paid, the scientific spine comes out. And before that loss, Cassidy supported other controversial health nominations despite clear vaccine skeptic records, decisions that were widely interpreted as efforts to stay visible with a base increasingly hostile to mainstream public health. Now, that is a part of the story that hurts. In the United States, our public's health is routinely subordinated to power calculations. When seats and committee assignments are on the line, vaccine science is negotiable. When the election pressure is gone, suddenly we can pound the table about damn lies and call mRNA vaccines what they are, tools that save lives and remain central to pandemic readiness. We shouldn't need a political exit pass to tell the truth about vaccines. Political health leadership increasingly requires political courage, and Senator Cassidy's post-primary stance is almost a case study in how differently science sounds when the fear of losing power is removed. ASPR's job is to prepare for emergencies, steward the stockpile, and guide BARDA's investments, including mRNA platforms. When the person nominated to run that system is publicly skeptical of vaccines and wants to slow mRNA development because he doesn't trust the existing safety data, despite extensive evidence that serious adverse events are rare and risks from the virus itself are higher, that's not just scientific disagreement, it's a security vulnerability. So the question for Resistance Radio listeners is simple. Why do we accept a system where a senator can speak frankly about science only once the political damage is already done? The standard should be, if it's true after a primary loss, it was true before the primary loss, and public health should not have to wait for defeat just to get a voice. All right, let's finish this video podcast with a bird flu story that should be quietly recalibrating our thoughts about the influenza or about bird flu. In late of 2025, a 75-year-old woman with Waldenstrom macroglobulinemia. I'm going to talk a little bit of shop here just for our clinical viewers, but I will kind of summarize everything. Who had been priorly on rituximab and bendamustine, and also with chronic lymphopenia, who developed fever and diarrhea. Initial nasal swab testing for influenza A was negative, but her chest x-ray was unremarkable. She was discharged with supportive care, no follow-up, no deeper look, just reassurance. However, the next couple of days, she developed cough, sore throat, worsening shortness of breath, and ultimately returning with what's referred to as acute hypoxic respiratory failure. CT imaging showed bilateral inflammation and consolidative opacities and requiring intubation. Basically, she went into very rapid respiratory failure. Despite repeated nasal swabs on days 10 and 13, they were still negative for influenza A. She was on broad spectrum antimicrobials, she was on steroids and maximal supportive care, and as well as lung protective ventilation, prone positioning, but her hypoxemia unfortunately progressed to acute respiratory distress syndrome. On day 15, a highly specialized center in Seattle, an influenza A virus was finally detected by a very highly specialized PCR from both nasal and bronchial lavage specimens from her lungs, and what it showed was that there was quite a high viral burden, but that was very low in the respiratory tract. That was hard to get to. Both specimens tested positive for influenza A, the H5, but sequencing confirmed a highly pathogenic bird flu virus, H5N5, which has no evidence of any genetic reassortment at this time. The hemagglutinin belonged to a clade that looks like it was part of the Eurasian lineage, with the same dominant HA clade associated with currently spreading H5N1 viruses. Okay, sorry, that's all the clinical stuff. What does all this mean in plain English? So this was a classic zoonotic spillover from an H5 virus that was already circulating in birds, but not necessarily a new reshuffled Frankenvirus. Intrahost dynamics showed that a mammalian adaptation marker, which was known as PB2, was low and declining in frequency from about 42% to 9% over 9 days, suggesting very limited adaptation and reminding us that fully avian viruses can cause severe human disease without optimizing for human transmission. Clinically and ecologically, the risk factors are hiding in plain sight. The patient lived on a rural property, fed and handled ducks and eggs daily without gloves or masks. 2 ducks had recently become ill with neurologic signs before her symptoms started. Epidemiologic investigations have not identified secondary human cases amongst her contacts and healthcare workers. But that's not the point. The point is how close we came to missing the diagnosis entirely. So here are the key lessons. Multiple negative upper respiratory specimens do not necessarily rule out a lower tract influenza infection, especially in an immunocompromised person with heavy exposure. So it's important for us to continue to look in the lungs. Delay in identifying this highly pathogenic bird flu, this so-called H5N5, meant antivirals were started very late in the course. And the patient, unfortunately, was already spiraling through ARDS. And of course, her underlying malignancy and immunosuppression likely contributed to poor outcomes. Okay, what does all this mean? So this means basically the CDC has noted that the bird flu is now widespread in wild birds globally. We know that. It's causing outbreaks in poultry and U.S. Dairy cows. We know that. But there are sporadic diseases in humans that are far largely in animal workers and no confined person-to-person spread in the U.S. at this time. The assessed public health risk remains low, but not zero, okay? But think of it like a forest with scattered campfires. Each one is small and mostly contained. But the more campfires you have, the more tinder there is on the ground. And that matters more for your firefighting equipment, diagnostics, antivirals, vaccines, and surveillance. So putting all this together, the New England Journal Andes virus review, the hantavirus that can spread person to person in South America, carried by rodents that we don't see in the U.S., but absolutely relevant for travelers and for any system that assumes exotic pathogens stay politely in their home zip codes. Climate shifts, migrations, and changing animal ecology are quietly rewriting who shows up in our ICUs with respiratory distress and how often we should be asking uncomfortable questions about birds, rodents, and travel history. So in 1 week, we have Cyclospora reminding us that food chains are a fragile global network, not a local salad bar. Measles proving again that vaccines work remarkably well when we actually use them. And the Andes virus and H5N5 showing that zoonotic spillover plus vulnerable host plus delayed diagnostics is a recipe for devastating but preventable mortality. And lastly, a Senate hearing where physician senator finally says the quiet part out loud about vaccine lies, but only after political calculus no longer matters. So if you want a unifying theme, it's this. Our microbes are exquisitely indifferent to our politics, but our politics are still shaping who gets sick and who gets protected, and lastly, who gets hurt. And with that, this is Resistance Radio, where natural selection selects resistance, and we're still trying to make sure that truth does too. Thank you for tuning in. I'm Mark Allendary.